I want to welcome all of you to the medical school class of 2017. If I could see you, I'm sure you're all a lot more relaxed than I was on my second day of medical school. I'm going to talk to you today about the future of healthcare because that, as you know, is the title of this series, or this lecture series. And I'm going to start off with one certainty, and that is that the future of healthcare has to be different than it has been in the past and than it is at present. And I'm going to tell you why it has to change, and I'm going to tell you how we together will change it. Because unless we partner with you, our patients, and our community, we cannot achieve what has to be done in medical care in order to provide all of our patients with what they have a right to expect in the way of care. As I move through this discussion, and this is the topic, I want you to keep in mind the concept of integration and see if you are persuaded that the future of healthcare mandates integration into healthcare teams. Because what we will be aiming for as we move along in healthcare delivery is healing partnerships, a care team together with the patient and their family. This has not existed in our healthcare delivery system in the past. So why do we have to change? We have to change because the cost of care is far too high and truly unaffordable. The quality of care is too inconsistent and unpredictable, and access to care is not available to too many of the citizens of the United States, the wealthiest country in the world, and we have 40 million people who are uninsured or underinsured. That is intolerable, and we tolerate it. What about the cost? This is a very easy graph to understand, going back to 1999 and ending at 2009, and it shows what has happened to, first of all, overall inflation of the rest of what we pay for in that period of time, 28% overall inflation. Workers' earnings stayed a little bit ahead of inflation, which of course you'd like to see happen during that period. And look at what happened to health insurance premiums. And that curve has gone steadily upward. The truth is, there with 40 million uninsured or underinsured, even the average family in the United States cannot afford to pay the average insurance premium today. This has to change. Now, the justification you will hear from those who want to mislead is that the best health care in the world is expensive, and therefore it should be that costly. The problem is we're far from the best. We have the best technology. We have inadequate access to care. You'll do much better in France. But we do not have the best outcomes. And I just put one example of many, and that is infant deaths around the world, and I chose just a few countries. This is infant deaths per 1,000 live births. Singapore, 2.55. Slovenia, number 10, 4.07. The USA, number 34, 6.92. Cuba is one ahead of us. So how can we say we are the best with these kinds of statistics? Now, San Francisco does very well, 3.4. Much better than the rest of the United States, and 70% of the non-Kaiser births in San Francisco take place at CPMC, so of course we're going to have that kind of statistic. So, the case for change. Three aspects: the state of healthcare, the state of the U.S. economy, and what happens nationally and internationally. The current state of healthcare in America, as I said, is too expensive, it's too inconsistent. The care is fragmented. Patients and their families cannot navigate the system. If you've ever had a serious illness, going from here to there and wondering if your primary care physician even knows where you are or what's being done for you and to you, it's fragmented and it's unpredictable and it's very disturbing to patients who are sick, who are so very vulnerable during their illness. Going along with all of that is we are paid fee for service. The doctors are paid fee for service historically, meaning the more we do, the more we get paid. The wrong kind of incentive. We were volume-based medicine, not quality-based medicine, not value-based medicine, volume-based medicine, and that's how costs got out of control so badly. On top of it all, the most important starting point for patients is their primary care physician, and I'll show you there is an impending shortage. If you turn to the U.S. economy, we're now 17 to 18% of the gross domestic product, one of the highest in the world, if not the highest, and it's continuing to rise. And most of the American public would think that we need some money for education, we need some money for defense, we need some money for Social Security, for Medicare. We don't want to spend our entire gross domestic product on health care, but it's still progressively rising. These high costs negatively impact our businesses' ability to compete globally. The auto companies in the United States spend more for healthcare premiums than they do for steel to make the cars. Not acceptable. And our economy affects the world economy. So as we go, so will the rest of the world. So we have to accept some responsibility for controlling our costs. And if you look nationally and internationally, if you have strong primary care, which we have weakening primary care, you have lower cost of care and you have better outcomes. And I'm going to show you how we're going to change that and how that will change the health care that you look forward to, respect, and have a right to expect. So let's look at primary care for a moment. We haven't changed primary care for a century. Still done the same way. You phone your doctor's office, you get a machine nowadays, you try to make an appointment. It might be in several weeks or a couple of months. And if the primary care physician is going to do everything that you need done for you to take proper care of you, he or she will have to work 22 hours a day on average. And this has been calculated, and this is scientifically based. Now, how are we going to do that? Which means you get shorted because not everything can be done. The average primary care physician taking care of a mixed population of patients under 65 and over 65 will have about 1,800 patients. Just imagine trying to do everything for that patient that that patient needs by yourself. So the primary care physician base is low, the number of primary care doctors is low, and it's dwindling. Now, what do we aim for? Well, the desired state is patient-centered care, coordinated care across the entire spectrum of care, shared decision-making with patients and families so they are fully informed and you do what they want you to do after they're fully educated about the situation, and increased patient self-management. Why would we take away the dignity and self-respect and autonomy of patients when they're at their most vulnerable? Why don't we ensure that every patient knows that we are partners in care and we will listen to you? And we will explain to you what your options are, and you will partner with us in making decisions. How often does that happen? Rather than you're being told what the right thing to do is, and you fear standing up for something you might want differently, particularly at the end of life, when you may not want heroic measures, even though they can be done. So what are the responses that are going on out there to all of this that I've just described to you that mandates change? From the payer's standpoint, the major payer of all of us in the United States, the doctors and the hospitals, is the government, through one government or another, through Medicare and Medicaid or Medi-Cal in California. And the insurance companies will usually at some point follow the federal government's lead on payment. So President Obama got through the Affordable Care Act, so-called Obamacare, which was appropriate because it will provide access to care, insurance, affordable, and care for 32 million more people. That has to be good. For those who can't afford the premiums, they'll be subsidized or their premiums will be paid completely. Now, how are we going to pay for that? We're going to pay for that through decreasing payment to hospitals and physicians. And the fear, of course, is, well, if you're not going to pay the physicians for Medicare enough to pay their overhead and make some kind of a living, will they continue to take care of Medicare? That's going to be an issue. And they're, of course, going to increase taxes. Another method they use is to shift the risk to the delivery system. When I'm being paid for the volume I do on a fee-for-service basis, I take care of you, the insurance company pays me. I take care of you twice, the insurance company pays me twice. What is going to happen is they'll give us a fixed amount. That's called capitation, cap at the head, one payment. They'll give us a fixed amount each month to take care of you. Hospitals and doctors will share that fixed amount, and no matter how much it costs to take care of you, we don't get any more. That shifts the risk of your care to us and forces us to be more cost-effective and efficient. What you've got to be sure of is you don't take care away from the patients because you have to pay for it out of your so-called capitation dollars. And we will shift from paying for volume, the more you do, the more you get, to paying for performance, to paying for value. And I'll define value for you in just a moment. So we will have quality measures that we have to live up to, and whether or not we get paid, both doctors and hospitals, will depend on how well we take care of you. Now imagine a concept like that, where we actually have to prove we add value to your care before we can get adequately paid. Why hasn't that been true from the day medicine was started? Of course we should pay for value and not for volume. We'll also not get paid when things happen to you that shouldn't happen. And when you are a victim of something going wrong in your hospital care, for example, we won't get paid for taking care of you to get this thing fixed. And that is called hospital-acquired conditions or never events. Now, these are things that should never occur. Now, let me give you a sense of the magnitude of what we as physicians and we hospitals are going to have to address and what's going to be looked at and be very transparent on the internet in terms of our quality. They will be measuring our quality, but not just how does your patient feel about you, but these kinds of things. I'll give you a moment to look at this. Every doctor and every hospital, these are doctor pay for performance, P for P is pay for performance. Every doctor on the left for the commercial population, 20 items for patients under age 65 that we will be rated for as to whether or not we are meeting national standards for quality. And if you're not, you're going to have a problem. And the patient will be able to look and say, does this doctor really do good diabetes care? And you'll be able to go online and see that Dr. Stewart is excellent in diabetes care because you'll be able to read online his results for these quality measures in diabetes care. And you'll know whether or not you should continue to go to Dr. Stewart or go to another doctor who has better value. For patients over 65, these 12 criteria that you see here. Osteoporosis management in women who had a fracture. There's specific ways to do that. And if you don't do it according to national standards, you're not going to be participating. This is not hocus pocus. This is real. We are measuring all of these now for our physicians in Sutter Health and what I call our physician foundations. This is very, very good for the public. Threatening to physicians, their self-esteem, their dignity, their compensation, but totally appropriate when it comes to the patient's rights to get the very best care. These are the hospital-acquired conditions I was talking about, the so-called never events that should never take place. I'll let you look through these bolded titles. But if you're in the hospital and you need a catheter, you had a gynecologic procedure, a surgical procedure, and you need a catheter in your bladder, and it isn't taken out soon enough, and you get a urinary tract infection, and instead of going home on the third post-operative day as you should, it takes you 3 more days to respond to the antibiotic. We pay for taking care of you for those 3 days. Medicare won't pay, the insurance companies won't pay. We pay for that. If we don't give you proper instruction and proper supervision, and you have a fall while in the hospital, you dislocate something, you fracture something, we pay to take care of you, not the insurance company, not Medicare. These are things that should not happen. And these are things that we will see to it that they don't happen. Shouldn't have happened anyway, shouldn't be a financial motivation, but now there's the additional financial motivation. So these are the list of hospital-acquired conditions that are never events. Are you starting to see an evolution of healthcare from the past and a transformation of healthcare? Now, these are the hospital quality measures that deal only with patient satisfaction that will be measured on. It's not just the science of medicine that we have to comply with national standards. It is also in the way the patients are treated, what I call the art of medicine, as Bill Stewart pointed out a moment ago. And these are the ones that will be measured in every patient. When you're asked to fill out a survey, we look at these results. You're not identified by name unless you ask to be, and you want to call. How was the nurse's communication? How was the doctor communication? Was it clean and quiet? How responsive was the hospital staff when you needed them? Was your pain properly controlled? Were your medications explained? When you were discharged, were you fully informed? All of these things are going to be measured in every patient and be published on the internet as to what the level of patient satisfaction is. That's good. It'll force the level of quality up. Now, all of these things that I've been talking about cost money. With the decline in payment from Medicare and insurance companies, which is progressive now, we've estimated pretty closely what just Medicare alone is going to do to Sutter Health, our system's revenue. And it's going to be true for Kaiser, it's going to be true for everybody. What's going to happen over the next 10 years. And We have estimated, I don't know if these dollars flying away are the butterflies in our stomach or just butterflies carrying dollars, but we will have a reduction in revenue from Medicare alone of almost $2 billion over the next 10 years. And we have to find ways to provide excellent care so that the patient never knows that we're going to have $2 billion less money to take care of you. Because you cannot translate your financial situation into impact on your patient care. And that's our challenge. This next slide is going to be very complex, but keep in mind that you are medical students and professors always produce the most difficult slides so they can show you how much brighter they are than you are as students. So with that, and I'm one myself, and I'm telling you, you've got to, there was a paper I read one time that said when you do this kind of thing and you ask them, the residents and interns, a series of questions and they can't answer this one, and you ask a more difficult one and they can't answer that, and a more difficult one, they can't answer that, you are depriving them of needless self-esteem. So I'm not sure I always agree with that, but it's a good story. So this is not the complex slide, it's coming. What are the employers doing? What are they looking at? The employers, when you talk to the human resources managers who manage employee benefits, and you say, look, we provide exceptional quality, and we do. It is worth more. You should pay more for it. And they said, look, quality is an assumption. I won't even be talking to you if you don't provide quality care for my employees. So that's a given. I'm not going to pay you for that. That's the starting point for you becoming one of our doctor groups. So put that aside. You don't provide quality, you don't even get to compete. Now, all right, we've agreed you're going to provide quality because that's expected. Now what's your cost? What are your fees? So they are interested in cost, and they are shifting from what are called defined benefit plans, where you get a list of the things that your insurance company will pay for, and your employer will pay the premium for that, to defined contribution plans. Here, employee is $600 each month. You go buy your own health insurance, and you do the best you can for the $600. The employer is contributing a defined amount. The employee, the consumer, becomes a shopper. Now, what's so bad about that? You do that every time you buy a nice fur coat. You do that every time you buy a car. Why should the economy of healthcare be any major difference than that? So now it's going to be competitive. And now it's going to be transparent quality, transparent cost, and the patient will have a choice because they're paying for it more and more. That's the complex slide. So how are we responding to this professorial slide? This is just our system. All systems are doing this. We start off by hearing the voice of our customer, which I've just been telling you. We look at the environmental trends and changes, Medicare decline, Medi-Cal decline, and so on, and we look at our mission, vision, and values. What do we live for? What are our principles? And then we assess the impact of health reform, our affordability, can patients afford us, our care delivery models, our pricing and revenue strategy, and our functions as a system. And each one of these has programs underneath them, including radical restructuring of the system, to change the way we behave, and then we implement an entirely new delivery system. So we are responding to what we are being told because it's inevitable. And all the systems are having to do this or they're going to be out of business. This is all transparent to the public. It's never seen. But it will lead to increased value, decreased cost, and increased quality. So the question, of course, is, I've been talking health economics and pressures and the like. The question, of course, is, has the patient been lost in the sea of healthcare change? Absolutely not. The patient is now, in my opinion, for the first time globally in the United States, taking the position in the center of care. And I'm going to show you how that is. This is what we teach all of us now, administrators, our residents, our physicians, our nurses, that the future is not volume-based care, it's value-based care. And this is the simple value equation, that if one learns nothing else tonight, one learns the value equation. And that is, to the consumer, the patient, the value of the care is directly proportional to the quality of the care. The higher the quality, the higher the value, and inversely proportional to the price. The higher the price, the lower the value. Quality consists of the science, which is expected. Why would you go to a doctor who isn't up to date? who doesn't know what he or she is doing. But it's also the art. It is the compassion, it's the sensitivity, it's the affection, it's the love for the patient, and the desire to partner with that patient to make them well. That's quality. Price is demanded, as I showed you a moment ago with the employers. And what we are now teaching our residents is that your scientific knowledge opens the door to successful practice. Skillful blending of the art, the caring for and caring about your patient with the science allows you to walk through the door and have a successful career. And if a young physician doesn't learn that, they're not going to succeed. It's just not going to happen. So we have to know, what do our patients want from the healthcare delivery system? It's easy. These are two studies done in the same year. This is a study of commercial insured patients between 21 and 64, 2,000 patients. This one is under 64 plus Medicare, 7,000 patients. Very consistent. What do patients want? Affordable health care, ability to participate in treatment decisions, and access to physicians who understand their needs. What is most important to them when they're older? The doctor caring for me understands my needs. My doctors make it a point to involve me in treatment discussions, provided I want to be provided health care I can afford. It doesn't say there my doctor has to understand the pathophysiology of malabsorption, because they expect you to know that. Bill Stewart doesn't know that, I do. But he knows a lot about orbital reconstruction. You wouldn't want me near you for that. Now, so what do employers care about? I want you to take a close look at this study, big study. Northern California employers, how important are the following factors in making decisions on what health plans to offer your employees? I want you to notice a few things. Quality ratings of providers? Employee expectations? Inclusion of specific providers? I want Brotman and Stewart for sure. No. Reputation of providers? No. They're interested in location, yes, because if you got to go to your doctor, they don't want you going too far away so you can get back to work. Premium cost. That's what and they're not bad people, but they're trying to keep their businesses alive so they can employ you. We have to keep this in mind as we transform the healthcare delivery system. So back to the title. Our goal, healing partnerships, the care team, and the patient. What does that mean? The healthcare transformation that Bill introduced is the transformation to what is now being called the patient-centered medical home. This is a model for team-based care in partnership with the patient and the family. And I want to tell you what that looks like. Here's how we formulate our response. You've already seen here's the market changes. Decreasing reimbursement, increasing complexity because we can keep patients well longer and alive longer, and we have an older population. They get more vulnerable to more diseases. Increasing complexity, increased demand because there are 32 million new insured people, decreasing supply of doctors. You have to transform the delivery model. And what is that transformation? Re-engineering of the ambulatory care team, not the doctor individually, the team. Greater patient engagement, leverage technology, which Dr. Stewart will talk about, and new payment models where you're paying for value and not for volume. Here are the major principles of the patient-centered medical home, and this will take a time to evolve. It's not going to happen tomorrow, but we will demand that it happen. A personal physician is the team leader, a team approach, comprehensive whole person orientation, not treating the disease, treating the patient. Coordinated and integrated care, get rid of the fragmentation. Quality and safety that is measured, measurable, and transparent. Enhanced access so you can get appointments when you want them and need them. And value-added payment, not payment just for seeing the patient. How will we put this together, the continuum of care? This is the continuum of care of the patient. Whether you start in the emergency room, in an inpatient bed, in a critical care unit, in an inpatient hospice with end-of-life care, or a hospital-based skilled nursing facility or rehab unit, or an outside skilled nursing facility rehab unit, your transitions of care will be managed by a team. And that team will have direct connections with all of these caregivers that you need in order to get comprehensive care throughout the continuum of your life. So this will be fully integrated care with management every step of the way. And here's what it looks like, the integrated care team. These teams will consist of a physician, nurse practitioner, a nurse, a care coordinator, a medical assistant, a pharmacist, a mental health professional, a physician, a patient service representative. Now, how are we going to pay for all this? Because of the efficiency, the added efficiency, and to tell you the truth, we don't know yet, but because of the added efficiency, instead of a primary care physician caring for 1,800 patients like I mentioned before, that physician may have 4,000 patients, and each of them will be managed in an integrated way. And if you're being paid a capitation for 4,000 patients, you can afford to pay for this kind of care as a practicing physician. So what will be different about patient-centered care as I bring my discussion to a close? Integrated team care with focus between visits as well. The caregivers, the patient, and the family are informed partners and active participants in the care. There will be no more myth, no more mystery. Each of the caregivers work to the top of their license. Physicians will do what only physicians should do, and they won't be doing the things that other healthcare professionals are licensed to do and perfectly capable of doing. The care will be personal, continuous, and coordinated throughout life. It'll not be reactive as we do today to disease. It'll be proactive, anticipating the patient's needs with a focus on preventive care. The transitions of care will be managed, as I told you earlier. We will have specialist protocols for chronic disease management and end-of-life management. We will have group medical appointments for people with diabetes, asthma, and things like that so they can learn from each other and become better partners in care. We will have open or advanced access for scheduling, both online and by telephone. And you'll get in because your doctor keeps 30% of his time available. You'll get in promptly. We'll have face-to-face communications in huddles among your caregivers and also communications through the electronic health record with emails and e-visits. Extended hours, so if you're working, you can get in at a time you can afford to be away from work. Every visit will have an electronic summary, and the patients will be continuously educated. This is not pie in the sky. We already have 2 pilots in Sutter primary care physician offices performing this kind of care. We haven't yet figured out how to make it affordable. How will we measure the success? Every parameter of care will be measured. We'll have affordability and utilization metrics. Are we putting too many patients in the hospital? Or could we keep them out of the hospital and at home? We'll have clinical quality metrics. We'll have satisfaction metrics, both all the patients, the staff, and the clinicians. We'll have growth metrics. Can we actually take care of the community that needs us with this kind of care? Every one of these will be measured, and the public will be aware of them. This is a growing problem, and this is what gives me concern. This was a paper published in November of 2012 from the Mayo Clinic, and they did a nationwide study of burnout among physicians. They found that 46% of the physicians they surveyed had at least one symptom of burnout. 87% were moderately or severely stressed on an average day. 38% had high emotional exhaustion. 37% their careers did not allow enough time for personal family life. 30% feelings of cynicism, and 12% low sense of accomplishment. This is very disturbing. And being a physician myself, when I was practicing full-time, if I hadn't loved the profession the way I do and loved seeing patients the way I do to this day, those hours of leaving home at 5:30, 6 in the morning and coming home at 11 o'clock for the first meal of the day would have been trying, particularly when the phone would ring again at 1 and you got to go back at 1 o'clock in the morning. You really have to want to do this, and most doctors do want to do it. The thing that's disturbing to me is that the highest rates of burnout were emergency room doctors, family practitioners, and internal medicine. These are our primary care doctors, family medicine and internal medicine. We have to improve their lifestyle, and the patient-centered medical care will improve their lifestyle significantly. So I want to close with what integrative medicine is really all about. It is more important to know what sort of person has a disease than to know what sort of disease a patient has. You've got to talk and deal with the patient. You've got to understand the impact of the disease on the patient and their family. They're not a disease. They're a whole person who has a current problem. You should cure sometimes, treat often, and comfort always. And wherever the art of medicine is loved, there's also a love of humanity. Who said these 3 things? Hippocrates, who was the father of Western medicine. Thank you very much.